Dr. Khan. It's a pleasure to be on Facebook Live, and a warm welcome to all our new members, and certainly to the members who are following us on a regular routine basis. This is my first Facebook Live with my colleague, my anesthesiologist, my MDA, who's been with us for those many patients who have had the privilege of being taken care of by Dr. Alex Lamar. And so we're going to have him talk about his expertise, his excellence in regards to managing and taking care of our patients that come from far away. So if you have any questions, please feel free to ask. And this is where we will have you introduce yourself.
Hello, I'm Dr. Alex Lamar. It's a pleasure to be here with you guys today. Hopefully I can shed some light on some of the issues you might have in anesthesia and put some things at ease for you. I am from Wayne State originally, and I went to Wayne for residency. Afterwards, joined a group, Ambulatory Anesthesia Associates, been with them, taking care of patients, doing this anesthesia work every single day, and progressing every single day. So hopefully if there's anything I can answer for you guys, please feel free to shout out some questions. We're here for you.
Mark, we had some questions for Dr. Lamar, so if you can read those, and please feel free to ask any questions. You can go on TikTok, comments, YouTube, Facebook, or Instagram, and you can certainly please ask your questions and we'll answer them live.
So the first question, I'd like to know how it's possible that you do deep sedation as opposed to full anesthesia, meaning for a surgery this long, minimum 4 hours, how is it determined that deep sedation can suffice?
Okay, well that's a good question. So you have to think about anesthesia as a continuum of different types of sedation. So it's not specifically one or the other. What we usually do is, so we get you in the room, we get you settled in on a bed, we start to give you some medication. At that point, what we consider that an anxiolytic or a mild sedation, because you're still listening to me, you can respond, but you just kind of don't care much and you're comfortable. And then we continue to give you more medication, and then that progresses into a moderate sedation. And what moderate sedation really means is that if I call your name, you just don't listen. If I touch you or I shake you, you may respond. And then we continue to give you more and more medication until you get to a deep sedation. Deep sedation is, of course, where our ultimate goal is and where we like to be, and what people say is a sweet spot. Deep sedation is giving you enough medication to kind of put you out to sleep so that you're not responsive to anybody touching you or any painful stimuli, but that if you were to feel something very hard or heavy or a strong stimulus, you would jerk or you would withdraw, but you're also breathing on your own. And that's the key feature between deep sedation and what people call a general anesthetic. General anesthesia means you don't breathe on your own. We have to assist your breathing, and you don't feel anything at all. That's different. That would require us to have some advanced airway things like an airway breathing tube or an airway, securing your airway and allowing you to breathe through that on a ventilator, such as this machine next to me here. You won't need any of that with this type of sedation. This is a deep sedation. You are breathing on your own. You cannot feel anything. Painful stimuli can, of course, be felt, but not through brain stimuli. It's more of a withdrawal reflex. So you're not remembering you were in pain. Your body would withdraw a little bit. We would see that. We would either give you more anesthetic, or Dr. Khan, of course, would give you more local anesthetic, which is numbing medication, at the site of the surgery. Both of which are very effective and work really, really well. But that's kind of what we do during this process. We're kind of balancing your safety, your comfort. We're giving you medications to keep you in that deep sedation area. And that's kind of where we like to be for the 4 hours. Now, once we're cruising, it's kind of like flying a plane. Once you're cruising and you know how much you've given this patient and how the body has tolerated it, you know how to put it into cruise control. And then the rest of the 4 hours advances just the same exact way. We just kind of keep it running. You're asleep, you're comfortable, and we're watching you. We're watching you, and we're very vigilant about watching you. We're watching your, vitals, your blood pressure, your heart rate. We're watching your oxygen levels. we're watching your body's response to pain. So if somebody feels pain, their heart rate goes up, and we see that, and we give you some pain medication. But at no point in time during this process is your safety jeopardized, and that's kind of why we like this deep sedation area.
Now, so to summarize, to date, having taken care of thousands of patients, not a single patient has said we have had any recollection of the surgery, we remember talking, and this is very well controlled and in seasoned hands and experienced hands, and with knowledge and experience and expertise. It is delivered in a very precise, thoughtful, systematic manner as I work with you and the other team members so that we are delivering truly excellence. Now, when you hear something, this is more for the movies. This is more like the TV dramas that I heard everything. To date, not a single patient, I will emphasize, has recalled, remembered, or heard the conversation. And this is where it is done in a very safe, effective way. Now, the other thing I want to mention here is that this is what you said, better, safer versus general. Like, what are the pros and cons of deep sedation and versus general anesthesia?
Okay. Well, one that's probably the most obvious, of course, is recovery. What we find is people who have general anesthesia with advanced airways, meaning something that's placed in your instrumented into your airway while you're sleeping, whether it's a breathing tube or any type of other invasive measure, people like that tend to recover slower after surgery, and so we have to watch you a little bit more after surgery. You end up with things like nausea and vomiting. That's a higher risk. You also end up with something called aspiration, where things come up from your stomach and go into your airway. That can happen. That's also at a slightly higher risk when you're having a general anesthetic. So obviously the advantages of a deep sedation, you don't have any breathing tubes, you don't have anything instrumented into your airway, which is wonderful, especially if you're a singer, right? You don't want anybody messing with your vocal cords. And then the other reason is the recovery is much faster. You wake up much quicker. It's very quick on and quick off. The medications we use for a IV sedation are titrated very tightly, and they don't last very long, so they leave the system really pretty quick. Whereas with general anesthesia, we have to give you volatile gases, and those tend to linger around for a while, because the only way to get rid of them is to blow them off. Whereas the IV medications, they go into your system, they make one pass in your body, and then they're gone. They dissipate really quick. And so we don't really worry about them lingering for very long. So recovery is much better, less nausea, vomiting, less risk of aspiration. And people end up doing, as far as scores go, people have satisfactory scores are much better that way.
Absolutely. So I just want to mention, most of us have had experience with the deep sedation when we have had a colonoscopy. Now remember, a colonoscopy is a 6-minute operation. A procedure, 6, 10, 12 minutes, depending on the polyps. So it's relatively very fast paced. They don't want to give you too much because then you will take longer to recover. This is where they're giving you just a touch. Now this is very different anesthesia with us, where we are doing it in a very controlled, effective manner for the 4 hours plus minus. And this is I use the word safe, compared to, for example, the general in my mind and eyes, and not only myself, but the many other doctors that I have taken care of. A month ago or so, we had an anesthesiologist husband who was here with his wife who wanted the implants removed, and he was very happy to hear that it was going to be the deep sedation that what we would offer, and not the general, because this was going to be effective. The other thing I want to mention here is, one of our patients voiced this concern: how can you operate on someone who is breathing in and out? And this is where, is it not dangerous? And I will say absolutely not. It is better that you as a patient are breathing on your own versus the ventilator, because at the end of the day, you're breathing regardless, be it the machine or be it the patient. And this is a very well delivered anesthesia. Yes, I don't want to use the word a moving target, but the patient's taking nice deep breaths. But the patient is in a very nice deep twilight state where I can effectively dissect off of the rib, removing the periosteum, the perichondrium, the fascia of the intercostal muscle, the fascia of the serratus anterior and the fascia of the pectoralis minor, such that despite the breathing, that it is done equally effectively well, be it the deep sedation or the general anesthesia. There was a case that I was doing at the hospital where I myself requested that patient be paralyzed and the breathing tube be placed. This was a very complex 68-year-old case, and I was able to do the surgery relatively very well, and the patient did very well. In summary, what you're saying, Dr. Lamar, you have a choice. Deep sedation is better, more practical, efficient, gets the job done, recovery is better, and you get the same task accomplished with less side effects.
Absolutely. Now, we do want to make mention, of course, that in the event we have to advance to an airway, we can do that, and we do that very successful. We are equipped with every single thing that we would ever need, from video laryngoscopy for difficult airways to all types of anesthetic gases. A very state-of-the-art machine, actually 3 of them. Dr. Khan is very generous. So we do have everything we need. If in the event your breathing were to cessate, you were to stop breathing during the procedure and I had to assist you, that is very easy to do. I can assist you in a multitude of methods. But if we ultimately had to secure your airway, we have the capability here to do that. So we have designed our anesthesia here by choice. This is it's not necessary that we are not forced to do deep sedation here. We're equipped to handle all sorts of anesthesia, but we've devised this type of anesthetic specific to patients who qualify, of course. But we've done this purposely because we find the results are the best this way.
Right, it's very controlled, delivered very effectively, and we make sure our patients are the correct and the right patients. So in our surgery center, we have patients with higher than 35 BMI, they have to be done at the hospital. A patient I took care of almost 8 weeks ago, she had severe subglottic stenosis, which is narrowing of the airway, and she had to be done at the hospital because every 6 months or so, she had to get the dilatation procedure in order to open up her narrow airway. So any of these patients with COPD at the hospital, the thought crosses my mind at the hospital, and this is where, as we team with anesthesia, my role, your role together is to deliver what is excellence, safety, number one, as you mentioned, and to make sure that we have thoroughly looked at the chart. And I want to mention, I myself independently review the medical clearance, and Dr. Omar, he ended separately as a different entity, as a provider, reviews the chart separately so that he has had a check and balance. I have looked at it, and my nurse also has had a look at it, and we make notes and review the charts and the medical clearances so that we have understood our patients very well.
Yeah, and that's one thing I really want to congratulate you guys on doing, because this is something that I haven't seen in any other facilities that we've worked at. And that's the collaborative note-taking that Dr. Khan has a system here where everyone collaborates on their notes. There's an anesthesia section, there's a surgeon section, and it's all on the same face sheet. And so we put these notes down, everyone can share these notes, can see what everybody else's concerns are, and we can collaborate and devise a plan for the patient that's very safe and effective, as you said. But that's a great addition, and I know that's kind of been one of the new changes that you've made, and it's worked very, very well, I have to say. So,
thank you. So, I want to say every team effort needs to be made because we are on team safety, team completeness, team effectiveness, so that in any given time, I understand you, you understand me. We are like our best friends inside the OR and outside so that we can deliver the best of care to our patients who are certainly very anxious and nervous, which everyone is, and so that they have the peace of mind and the way you talk and approach them, you've already reviewed the chart. The other thing I want to mention here is that you have to share with us, there was a question on vaping and nicotine. If you can please address that from your end.
Yes, so I will say that it's a very gray area, and I'll tell you why. First of all, smoking is very clear cut. People can tell you it's been studied very well. Someone can tell you that 2 weeks of cessation of smoking, you start to get some of your cilia back in your lungs. Those are the little cells that kind of expel all that mucus and help you clear coughs. So someone who stops smoking cigarettes, for example, for a few weeks will recover those cells. And then after a month, their airways are more clear than they were, and that's usually the optimum time to operate on somebody. If they've stopped smoking for a month, of course, if you quit for a year, hey, that's great. A year, almost lungs probably look like the way they did before. But with vaping, this is a new area of study. Now we know it creates things like popcorn lung, and it has effects like that. What we don't know is the timeline. When should you stop vaping? What I would say, if you are somebody who has planned surgery and your surgery is within a month and you haven't stopped vaping already, I would say stopping immediately before surgery is not a great idea. And the reason being is it increases your stress level. You don't want to go into surgery with a higher stress level. The surgery itself is already an inciting agent for it to increase your stress. So what I would say is if you're able to, if you know out in advance, try to stop vaping 2 weeks to a month before, recover some of those cells, those cilia back, so that you can clear some things after surgery if you needed to. But for the most part, if you haven't, it's okay. It's not the end of the world. We can still provide safe anesthesia. The risks, obviously, afterwards of respiratory problems like a cough or having increased secretions, things like that, is a higher risk for you. But what I would say is still better than quitting just before surgery. That risk, that higher stress level, is not great for you. 2 weeks before is good. A month is excellent. Anything more than that, of course, is wonderful.
So very good point. The moment you quit smoking, that same second after, you're going to reap the benefits of smoking cessation. Now, this has been extremely extensively, heavily studied in the world of plastic surgery. So if someone were to get a neck lift or a facelift and they're smoking, the surgery is contraindicated. Absolutely, the surgeon should cancel, because there's going to lead to skin necrosis. Just like it says it's going to lead to a heart attack, we don't want an attack of the skin where the skin is going to necrose. Now, remember, this is, I use the word elective surgery, right? It's not an emergency. You want to put the best foot forward going into the surgery. You don't want to take any chances. So the textbooks have said 6 weeks before. Now, if you can do 6 weeks, or like you said, a year, excellent. 6 months before, excellent. 3 months before, excellent. 6 weeks, that would be, now it is the easiest thing for us to say, the hardest thing for you to do, especially if you're sick and stressed, and if it's a habit, we want the best foot forward going into the surgery. Now for me in my practice, we have what is called the honor code, in a sense that, one of my other plastic surgery colleagues, he checks the urine, for example, and makes sure that, the patient's not smoking, and then he proceeds with surgery. I say, we're all helping each other in order to achieve the goal of no complications post-op. So we don't want to look back and say, we wished we had stopped smoking. So for your own good, so that you have this control, stop not only the smoking, but the vaping. The vaping has been shown in those 17-year-old kids that are smoking and that have lungs of that of a 70-year-old, not worth it. And you will eventually end up paying the price. And it's certainly not only the nicotine, but that strawberry flavor, that chemical that's inside, that's only going to cause the hurt and harm. So for you, regardless of the surgery, this is stop smoking, stop vaping. You will end up eventually paying a price. Now, I will tell you, this is ultimately your choice. And at least for the surgery, whenever we have control over something, we want to be able to say that we did the right move, we put the best foot forward, so that when we look back at it, we could not have done it any better. Now, the other thing I wanted to mention, Dr. Olamar, from your experience of having managed thousands of patients with marijuana, and also not only THC, but what is your take on that?
So now more than ever, right? There's different strains, there's different types of marijuana. I can't even keep up with how many different types of marijuana I've heard patients say that they smoke, or edibles that they use. Now the biggest problem we see, of course, is interactions with medications. marijuana has great benefits, of course, for people who are using medical marijuana. I'm not advising against it, I'm not advising for it. What I am saying, though, is you have to always be aware that there is interactions with medications that you may not be aware of. From what I've seen mostly, waking up from anesthesia tends to be a little aggressive. We have violent wake-ups. They actually have termed them marijuana wake-ups. And we see that a lot more with general anesthesia, but up to an extent with deep sedation as well. And that's when people flail. They wake up, they swing their arms around, they're confused. The THC has suppressed the brain so much that now that they're excitatory, they don't know how to hold that back and inhibit it, and they swing their arms around. Sometimes they can get very aggressive. It's very hard to readdress them, try to get them to understand where they are and what they're doing, and that they've had surgery. Sometimes no matter what you do, it doesn't help. Sometimes we just have to put them back to sleep for a little bit. So we do see that. We call it marijuana wake up. My recommendation, of course, is to not be smoking marijuana before you have surgery to avoid these sort of things. But again, especially nowadays with the different types of marijuana, no one can be for sure, no one can be certain it won't interact with something that you're taking when you're on the table. So it's best to avoid it, especially 3 days before. At the hospital, we don't let people smoke marijuana 3 days before surgery for those specific reasons. Right. But even with long-term smokers who don't smoke before surgery, we see these effects as well. Right. So some say that obviously this is a lingering effect of marijuana that's just difficult to get rid of.
Sure. Now, this is my take on it. This is my opinion. As you can see, I have strong opinions about a lot of things, especially when I have knowledge and base and we read up on the medical field. One of the worst things that has ever happened to our society, with all due respect to anyone who's doing THC, be it smoking or gummies or whatnot else, is that permission to use marijuana on a daily basis. It is now clearly, without any doubt, showing increase in heart rate, young kids with their mental effects that the marijuana has had, and these are very well published studies. And unfortunately, the government of the US has stepped up and allowed this and permitted this. Yes, it was used quite a lot, but that doesn't mean that you allow for something that is harming society. Be it young kids or the 65-year-old mom who's smoking because she has the many symptoms of breast implant illness. You should not hurt your body, because there will come a time where you will have to pay the price. So do no harm. That's the oath we took, and I will tell you, as a physician, as a clinician, as someone who reviews the medical literature just like as you and I do, it's not worth the harm and the hurt, be it smoking, be it the vaping, and be it the marijuana. And I want anyone to tell me that these are all good. Now, if someone's taking it for seizures, that's not my area of expertise, but I'll tell you there's certainly a role for that. But for someone to doing it recreationally, it is absolutely bringing down society, and this is not what I would call habits that will promote good or health, but these are sometimes habits that ultimately compromise the quality of life and absolutely the length of life as well, meaning it basically is showing that people are getting a lot more heart attacks, and certainly wound healing, seroma formation, amongst other problems that indeed absolutely do occur as a result of all three, if you will. Now, the other thing I wanted to talk about is the GLP, Ozempic, and also the many other medications that everyone is using nowadays, millions of Americans, where they're basically allowing or altering or slowing down their gut stomach. For example, the gastric emptying. So you may have had solid a day ago, and a scope was done, let's say, by my GI colleague, and is still seeing solids in the stomach because it truly did not empty. We do not want this on the day of the surgery to basically be an issue where it may potentially end up being in the lungs. So in my practice, I tell my patients to stop at least 3 weeks before the Ozempic, for example, and then the 48 hours, 2 days before the surgery, just taking clear liquid, so that when you do come to us, that you're essentially in the clear, and then we still, I have discussed this with Dr. Omar, we still put a tube down because we don't want to take the risk of whatever is in the stomach to be put into the lungs. So essentially this is what we call like a zero chance problem, because we have full control with the tube. If you can please elaborate on that.
Sure. So, you know, you make a good point. We've pretty much covered every corner when it comes to GLPs. It is an evolving world with GLP. Almost every other person is now using GLPs some way or another, whether it's oral, IV, and the studies on when to stop GLPs continues to change. A lot of that is, you know, driven by the market. But Dr. Khan has been very, very diligent about making sure his patients stop the GLPs 3 weeks in advance. And on top of that, we still provide a general anesthetic with an endotracheal tube. And the reason we do that, the consequences of GLP, its aspiration is the big one. Residual food in the belly, anything that comes up into your airway is considered an aspiration. It could be a micro aspiration, a very small amount, it could be a large amount. The problem with it is a small or large amount, this is a significant event. This is an event that might require you to be hospitalized and treated supportively, because there's no treatment for aspiration. There's no treatment for aspiration, and if you were to develop a pneumonia from it, even worse so, there's no treatment for that except support. So you're in the hospital, you could be even in an intensive care area, and you would require oxygen support. You would require 24/7 doctors rounding on you, making sure you're okay, possibly steroids, antibiotics, all of which would be more or less a trial. Nothing has been shown to be effective besides time and letting your lungs heal. Some people, unfortunately, their lungs don't heal from an aspiration pneumonia, a pneumonitis. They get this chemical injury in the lung and it just doesn't heal. They'll have residual effects for life. So this is something that we take very seriously. So although this stuff is being sold on the market, online, you can get it pretty much anywhere you want, we are very, very cautious about who gets anesthesia, what type of anesthesia we provide. And so for that reason, everyone, whether you've stopped it or you haven't stopped it for a month or more, we would still advise that you get a endotracheal tube with a general anesthetic so that there's a breathing tube in, securing your airway. Nothing can come up from your belly and go into your lungs because it's protected. And it stays protected until the second we're done with surgery and you're wide awake and that tube comes out. We give you medication to make you forgetful so that you don't remember it was there, but it was there. And we do that for very specific reasons. But this is the GLP world we live in now. These are things we have to think about and take into consideration, especially if you're going to have surgery.
So, thank you very much. That was a very nice explanation. This is not overkill. This is safe. If I'm the patient and if I'm on GLP-1 in the world we live in, and the 1,500 or so doctors that I've talked to on and off over the last 10 years, for example, and I talk to my GI colleagues, I talk to my other plastic surgery colleagues. For example, another surgeon in California, he had asked the patient to stop the GLP-1 3 weeks before, and lo and behold, they put a gastric tube into the stomach and they found 300 cc's of gastric contents. This is where the endotracheal tube is going to prevent that, correct? And so this is where safety, and this is the utmost number one concern, so that we are delivering excellence, we are delivering all the precautionary measures are undertaken going into the surgery, and this is where we are taking the responsibility so that there is no second chance for anything, because we're already going all the way up. Other surgeons will, for example, do 3 weeks and then it's okay for solids. I say, you know what, we're going to take up 5 more notches because this is safer, better, more effective, and the patients have done indeed relatively very reasonably well. And I invite other surgery colleagues, plastic surgeons, to listen in and follow from our experience. There's a surgeon right here in town, 35-year seasoned, experienced surgeon who I look up to and I salute as a board-certified, reputable plastic surgeon. And he had an aspiration with the GLP-1, and this is where I said, all right, this is where I'm going to learn from that experience, the other experience of my California colleague, and we're going to say, you know what, we're going to put the best foot forward so that when we look back at it, we could not have done it any safer. Now the next point, again, I'm just thinking extempore. By the way, we rehearsed 0 seconds for this,
Oh.
right? Yeah. We did the 2 cases together.
I'm actually sweating, you just can't see it.
No, I have to say, Dr. Lamar, it's, we get to know each other so well. We spend more time here with each other than our own families.
Sure.
You're my family outside of home and my entire team, so it's a blessing to
It's very
have
good.
you. Yeah. So the other topic we want to talk about here is DVT, deep vein thrombosis.
Yeah.
Yeah, so if you can please tell us what is it that we do here from an anesthesia perspective. And again, everything that we do is together, collaborative, so that we're taking the precautionary measures.
So there's a few things, of course, anybody who's having surgery, someone's going to be on a bed, you're going to be immobile, and you're having stresses of surgery, you're having trauma, because we're going to be getting into blood vessels, we're going to be getting into skin and tissues, and all this stuff causes inflammation. These are all prerequisites to getting a DVT, whether it be in your arms, your legs, somewhere in your body, you can get a DVT. Now, what we've done here is to ensure that we've taken care of some of the most important areas. For one, normal thermia, we keep you warm. We don't let your body clam down. We don't let you get cold during surgery. These are risk factors for forming of blood clots. We also make sure that we give you heparin before surgery. Heparin is a blood thinner. We give that to you by injection so that it works immediately. And it lasts a perfect duration. It gets us in through surgery, and by the time you're done here and you're gone, it's out of your system. So you're not really worried about taking anything home with you either that you don't necessarily need or that puts you at risk for bleeding. But it does work. It helps thin your blood, so while you're sleeping, your circulation is a lot more laminar and flow of blood is a lot more ease, so that you're not getting these blood clots forming in your vessels. The other thing is we put SCDs on you. We can make sure that as you're sleeping, there's muscular work being done, blood flow is moving through your legs so that nothing is stagnant. We don't want blood settling down anywhere in your body. All these are prerequisites for DVTs. Is there anything else that you want to add?
So we have all of our patients get compression socks on. So they put them on the morning off, and let's say if they're traveling from Toronto or from Chicago, or they're going to be heading back to California or Arizona, they take them off once they have landed, so that air flight back. 80-90% of our patients travel to see us, and so that when they're back home and ambulating and walking, their chances of getting a clot essentially non-existent between the heparin subcutaneous shot, between the 5,000 units, between the sequential compression devices, which is the SCD boots that Dr. Lamar was talking about, between the compression socks, between the out of bed to chair on the day of the surgery and the following day ambulating, walking about. And then last but not least, the deep sedation where you're not paralyzed, and chances of you getting a clot certainly almost brought down to 0. And this is where we go out of our way and to make absolutely sure. There are some patients that, for example, you very well, Dr. Lamar, last week reviewed a chart, and this patient was a von Willebrand. If you can talk about that.
Yeah, so we have a patient with von Willebrand's disease, and patient needs surgery. Patient has a history of bleeding with surgery in the past. So these are things we obviously are concerned ourselves with, especially when we're bringing patients in for surgery. First thing we did, and we do this weeks out, we sat together, we looked in the patient's chart, we looked through the patient's history. What kind of bleeding, how much bleeding, is it safe to do this patient? What do we need to ensure that we get a safe delivery of anesthesia and surgery and get this patient through? And we decided that the best thing to do would be to pre-treat this patient before surgery with DD-AVP, which is a desmopressin, which is a medication to help this patient actually stop bleeding. So these are things that are very important to us, that we ensure that the patient has everything that they need before surgery, regardless of what disease state that they have. But we do ensure that we collaborate and we plan weeks in advance. So when you come in here the day of surgery, there is no question as to what we're going to be doing for you. Everything is prepared, everything is ordered and here and ready for you. So the next thing we really have to do is just deliver it successfully, which you've done very well.
No, thank you. So this is, I tell all my plastic surgery colleagues, general surgery colleagues, orthopedic colleagues, ENT, urology, every patient that must be operated on must have a medical clearance from the primary care doctor or the cardiologist or whatever subspecialist that there is, if there is underlying, for example, liver issues, from a hepatologist, for example, so that we know that the patient's been optimized the TSH, iron levels, all of those numbers, labs, everything is optimal, the patient's being checked. And because my patients are traveling to see me, even if they were local, I want to know that the primary care doctor has given the green light to proceed with surgery, and so there's no surprises. This is very similar to flying a plane. You don't want to just fly and then, oh, we did not check the weather, we did not check the oil pressure, we did not check the gas. No, this is where we have a very thoughtful, systematic, organized way where we have a lot of information, and it is one-on-one care, independent by me, by Dr. Alamar, so that there is a care and thought process. Everyone gets my cell phone number. So if someone's having diarrhea from the antibiotics that you gave, for example, or the patient took by mouth, I want to know about it 24/7. There is a patient that, you know, had, for example, some the pain, for example, and it turns out, I asked her, are you moving your arm? And she said, yeah, 95% of the time I'm excellent, but that 5% of the time, and she had what was a spasm. And she's asking me to take, you know, a muscle relaxant. I said, no, the treatment here is no movement means no pain medication requirement. Now, the other thing that, you know, so the bottom line here is we want to proceed in a very stepwise, safe, systematic, thoughtful, everything, every movement, every line, every word has a purpose, and surgery is a big deal, and we want to make sure that, as you can gather from this information, there's so much that we have talked about, it's so much that we do behind the scenes that makes the surgical experience for the patient and the anesthesia experience. This is the best that we can deliver because it's all about being safe and delivering excellence. Now,
well, I just wanted to add, you mentioned something, you said systematic, and I just want to stress how important that is because it's something I think if you don't, you should pride yourself on. We do have a very systematic approach here. We do it this, and I think you've said this a million times in your videos to people, we do this the same way every time for everyone. And that's the key, is that by systematically doing this the same from the time you enter until the time you're on the table and the time you're off that table, everything has been done systematically the same way we would do it for anybody else. That's why our results always come out so consistently well, because we keep doing it the same way and we've had success with it. And when something is not successful, we've been very prompt to change it. I feel like you and I have talked about 1,000 things that we decided we should change, and we changed them. And our results have been tremendous because of that. So systematic is a very important thing that also should bring people some ease, because from the second you come in to the second you leave, this is not our first rodeo. We've done this many, many times the same way for every single person.
Right, and you know, it is a blessing to work with someone like you, the first assist, the surgical tech, the nurse, you know, from MAR to our front desk, and this is a whole collaborative experience. If you ask me, anesthesia is as important as surgery, and it's all put together from the intake from your primary care doctor. That is supremely important because we're getting official medical information from the provider, not from the patient. And there is all attention to detail. Now, the other thing I wanted to talk about, Dr. Lamar, is if you can expand on Exparel that we give to the patients.
Sure. So Exparel is really, it's just a fancy way of saying bupivacaine, but it's a fancy type of bupivacaine. It's a bupivacaine that comes, which is a local anesthetic, but it comes manufactured so that it's sitting inside of protein vacuoles, little houses. And every once in a while, they pop open and they release that medication. And so you administer it into the skin where you're operating, or into the muscle where you feel the pain is going to be localized. And what ends up happening over several days is every once in a while, those vacuoles open up and some more medication comes out. And that medication that's sitting inside of those vacuoles usually lasts about 18 hours. So every once in a while, you release some of those more and more of those vacuoles, and it ends up giving you a good total analgesia time, which is, you know, no pain time of up to 3 to 4 days. So that's a really, really helpful thing that people have started to institute in surgeries, whether it's your, you know, breasts, or it's your shoulder, or it's your knees. People are using Exparel a lot more now. It is pricey, but it's actually very, very effective. So I think when you look at, you know, price variations across the board of other medications versus Exparel, it ends up being very worth it. You know?
Absolutely, absolutely. I always jokingly say, would you rather deal with the pain of constipation or the benefit of getting the Exparel? The fact that you're not gonna get nauseous from the Norco or the Percocet, or the benefit of the Exparel. And this is what I say. Every surgery that's done on earth should get Exparel, because why take something for pain? And if you're gonna have pain, you're gonna have it for the first 3 days, and you might as well get Exparel. But this is cost prohibitive, to the point where, for example, I did a case at the hospital. The patient said, I want Exparel. We called the pharmacy, we called the hospital, and we said, we want to get the Exparel, and they said, we have no such thing like that here, and we will not order it because the insurance is not going to pay for it. And this tells you that's cost prohibitive, and you would think the children's hospital will use it routinely, at least for the kids or the other many surgeries that are done. But again, as you will see, Exparel works, it is effective, and truly, even if that 30, 50, 70% of pain is alleviated, it is absolutely worth every cent. Now, Mark, do you have any questions you see from anyone or from before that they submitted to us?
So I just had one question regarding blood pressure cuffs, if you put them on both arms during the surgery. One patient asked that.
Okay.
Do you put them on both arms?
No, we don't
Okay.
put them on both arms. So what we usually tend to do is, when you come in, we have to start an IV. On the side, we start the IV. We like to prohibit anything from being on that side, because that IV is our lifeline. That's what we use to give you medications. That's what we use to ensure you're comfortable, and that's what we use to wake you up and make sure you're not nauseated. So we like that IV being protected. We're very cautious as to even who touches that side. So what we tend to do is put a blood pressure cuff. We put a little stocking so that the blood pressure cuff is not directly on the skin. Anytime the blood pressure cuff is on the skin, it can tighten the skin. It can cause some redness around the area. We don't want that. We put a stocking on first, and then we put the blood pressure cuff. And the blood pressure cuff goes onto one area. If we need to reposition it, if for any reason it's not working well and we're not getting good readings, or for whatever reason it's being disrupted, whether it's somebody leaning on it, or we remove it, we can put it on your lower extremities, on your legs. We have access to all your extremities. So this is not a prohibitive surgery where we're prohibited from going and getting onto your, working on your legs or working on your arm. We have access to all your extremities. We have access to all our monitors, and we can play with them as needed. But yes, to answer your question, we do not put 2 blood pressure cuffs on. That's only for robotic surgery, where you start with 2 blood pressure cuffs.
Sure. Now, the other thing I want to mention, if someone has had a mastectomy, breast cancer on the left side, in not even the axillary lymph node dissection, we avoid the left arm completely, and this is where Dr. Omar would put the cuff on the right, and or the IV on the right, or IV cuff on the leg, for example, and we are able to monitor you very effectively. Any other questions, Mara, that you from before?
No, not related to anesthesia.
Okay, all right. No, I will go ahead and we'll do another Facebook Live where I'll go ahead and answer the questions on the pseudolift, on the surgeon choices, if you will. I think we've covered everything. It's a true pleasure to have you on.
Thank you very much. I appreciate it.
Yeah, anytime. A lot of patients have a lot of questions. I say to you, please ask those questions. Have that inquisitive mind. Dr. Omar, I'm sure we'll do this again in a few months.
Absolutely.
And then I think we've touched on all the basics
Where are we located?
Yes.
Everyone wants to know.
Yes, so where are we located? So we're here in Bloomfield Hills, Michigan, which is one of the northern suburbs from Detroit, 30 minutes or so away from Detroit. Our other location is in Northridge, California. This is where I hope to be every 4 to 6 weeks, not only seeing patients, but operating as well in Northridge, California, which has been, relatively speaking, very popular. We have filled up our November dates. We will be there in the first week of February, and hopefully more often as our patients allow and the schedule permits. The take-home message here is, for those many patients who are learning, get the knowledge source should be very defined directly from the doctor. How much do I know about anesthesia? 0.
I think you're better. You've gotten better.
No, I rely on you because you deliver it day and night. You know, you've been taking call, you provide excellence of care. Difficult patients with BMI of 67, patients with gunshot wounds, for example, to the chest, you're managing those patients inside the hospital. We want the patients to get that knowledge base directly from the doc, not from another person who runs a nail salon and she has an idea about what is deep sedation and she will go on text and try to write something that will make the next patient anxious. This is where the knowledge base needs to come directly from the person who's experienced, seasoned, thoughtful, meticulous, and overall, if you ask me, respects the whole process of what is delivering excellence in care. And this is where talking to the doctor directly is key. In my practice, in our practice, that is, you come, you talk to Dr. Lamar, you have any questions, please have them ready for him. I cannot imagine any other question that we have not discussed in the last 45 minutes or so that has not been answered. Anything specific, we want you to communicate with us. We want you to put your best foot forward so that as we go through this process of surgery and explant or whatever other surgery it may be, that you get all your questions answered and that you get the best care. And with that, Dr. Lamar, I will let you finish. Anything you want to add or say?
No, honestly, you mentioning people taking advice from Google or salons, or I would say, there's a saying, they say, the proof's in the pudding, and I think look at patient testimonials, ask people who've had the procedure how their experience was, call in, request from us. We can take you through a walkthrough of how we do things at the facility. What step one coming in, how everything goes after that, to put your mind at ease. But I would do all your homework before you take advice from people who are not medical professionals, because it can really throw you off, and you never really know what their intentions are. So it's best to ask people who do this every day. We love to answer questions. We love to help you out. That's what we're here for when we're not working. So please feel free to reach out to either one of us anytime you want. We're here for you.
Thank you, Dr. Lamar.
Thank you.